Hi there, this is Dr. Avinash here. I am talking about anti-leprotic drugs in this video, and let's talk about it then. The causative agent is Mycobacterium leprae, and you know how it is spread. So basic things you have already done in microbiology. I just want to bring to your notice that there was this oil made from Chol Mugra plant. So this had anti-leprotic properties, and it was actually used in Indian medicine for centuries before sulfonamides and its higher, let's say, drug dapsone was found to be anti-leprotic, and that's where dapsone became the main drug. Slowly and gradually more drugs kept on getting added, but just remember that once upon a time Indians used Chol Mugra oil. For classification, we are going to use a very simple classification. The first one is a sulfone called as a dapsone. This is followed by phenazine derivative clofazimine. You need to know these two drugs properly. The next is antitubercular drug rifampin, ethionamide, and then there are some other antibiotics including ofloxacin, moxifloxacin, minocycline, and clarithromycin. Simple enough? Very nice. So moving ahead, let's have a look at the very first one, dapsone. This is diamino diphenyl sulfone. You don't really have to draw this in your in your exams, but just know that this diamino diphenyl sulfone, that's why it's also written as DDS. It's the simplest, oldest, cheapest, and the most active and the most commonly used member of this category, sulfone. All other sulfones are useless. This works amazing. The mechanism of action is exactly similar to sulfonamides. I hope you remember sulfonamides working by action on PABA. So same action. If you don't remember, please go through the video for sulfonamides one more time. It's very, very important. Now, just like sulfonamides at lower doses, this is going to be static. So this is leprostatic. Apart from that, at higher doses, it might become leprocidal. But at the dose we give, it's static, leprostatic. Okay. At higher concentration, other drugs, bacteria might be inhibited. The reason why dapsone is preferred and not other sulfonamide is because dapsone has a particular affinity for the Mycobacterium leprae folate synthase enzyme. Okay, so that's the reason why we like this particular medicine here. The resistance is kind of primary or secondary, and there's this problem of persisters. Okay, so before we go to the next part, let me help you out with what is primary resistance. This is what happens. Imagine you meet a patient of leprosy. He never knew he had leprosy. He has never taken dapsone ever in his life. You check his leprosy bacteria and it is resistant to dapsone. This is primary resistant. It is basically an originally resistant bacteria in the patient. Of course, he got it from somebody else, getting it? But now look at this. You have a patient who has a bacteria of leprosy who is susceptible to dapsone. You start the monotherapy with dapsone. Given sufficient time, the bacteria will become resistant to dapsone. This is called as secondary resistance. Right? Secondary dapsone is people who are treated with monotherapy. Primary dapsone resistance is primary. It has happened in people who were previously treated with dapsone, and then they started spreading the disease to other people. And then there is this problem of persisters. Okay, what is this problem of persistence? There are some drug sensitive bacilli. The moment you give dapsone, they just stop growing. They become dormant. They hide in some tissue. They are not affected by drug at all. At a very later stage, maybe 5 months, 7 months, 10 months later, when the drug is stopped, they might just start working back again. So that is the third important problem. The idea is to give dapsone in sufficient concentration. The good news is the dapsone that we give, 100 mg per day, with this dose, the serum concentration is so high, it is 500 times more than what is minimum inhibitory concentration for leprae. So 100 mg is like too much of a dose. If you combine this with pyrimethamine, you can treat falciparum malaria, Toxoplasma gondii, and Pneumocystis jirovecii very, very easily. The dihydroteroase synthase or folate synthase enzyme is inhibited by dapsone. So that's what you have to remember. Dapsone has some side effects though. It is an oxidant drug. Now, if you have done sulfonamides and cotrimoxazole sincerely, these are similar side effects. Mild hemolytic anemia, especially in G6PD deficient patient, some gastric intolerance, methemoglobinemia, headaches, paresthesias, mental symptoms, drug fever. Some people get side effects such as rash and fixed drug eruptions and hypermelanosis where the skin becomes blackish in color, phototoxicity, and even exfoliative dermatitis can happen. And very, very rare complication is hepatitis and agranulocytosis. You also have to know something called as a sulfone syndrome. This can be an odd question. This happens 4 to 6 weeks after dapsone treatment has been started, and it presents as fever, malaise, lymph node enlargement, desquamation of skin, jaundice can happen, anemia can happen. So this is how desquamation takes place. It looks as if the skin is peeling off. This is way common in malnourished people and taking MDT or multi-drug therapy. Stop dapsone, start corticosteroid, the patient will be absolutely fine. I hope you have understood this. Don't forget to write that it is also used in malaria, toxoplasma, and jirovecii infection. Okay, very important points. Moving on to the second drug, clofazimine. No, you don't have to draw this structure in your exam. You just have to remember that this is a dye with a leprostatic and anti-inflammatory action. Now, how does it work? God knows. We have some theories. The first theory is it interferes with the membrane. So it alters the membrane structure and its transport function. Second, it inhibits Mycobacterium phospholipase A2. And by doing that, it does not allow proper membrane structures to form. Third, it inhibits microbial potassium transport, because of which electron transport chain gets disrupted. And fourth, it generates hydrogen peroxide and it kills the bacteria like that. It is also known to interfere with bacterial electron transport chain, which means the bacteria is now literally going to starve. Now, additional actions that are present in your newer textbook is it interferes with the template function of DNA. So DNA cannot become mRNA, mRNA cannot become protein. So the bacteria is starved for new protein. It can't execute its day-to-day activities properly. So that is one way by which we can think about clofazimine. Simple. Clofazimine has antibacterial as well as anti-inflammatory effect because it inhibits macrophages, T cells, neutrophils, and the complement system. Simple. Now, if used alone, one, it will not cure the patient. Instead, it will develop resistance. Don't do that. Secondly, it is known to accumulate in fat cells and macrophages in the form of crystals, needle-shaped crystals. So be careful because these needle-shaped crystals can eventually hurt these macrophages and other tissues where it is getting deposited. So be very, very careful. These are the crystals. This is how they will look. The TF is 70 days. So long acting, it is very long acting. The adverse effect is kind of important. It gives a reddish black discoloration of the skin, hairs, and secretion. The skin becomes dry and itchy, and acne-form eruptions, acne-like eruptions start on the skin. Some people even get conjunctival pigmentation, which kind of is permanent. So it looks horrible, it looks bad to have such kind of a problem. Other symptoms are more like loose intermittent stools. This actually now is attributed to either one, the irritant action of clofazimine, which is in the initial part of the treatment, but in the later part people believe that it is because of accumulation of that needle shaped crystals in the intestinal cells. Okay, simple answer it is, go through this, very, very important. Without going through the textbook, if you write only what I have spoken, you will get barely passing marks. I want you to score amazingly high marks, and hence please go through the topic. Which brings me to rifampin, a potent cidal drug. This is the most potent leprocidal drug. It renders the patient non-contagious. That's why we love this drug. It gives rapid recovery. 99.99% bacteria are killed in a span of 3 to 7 days. There are some nasal symptoms. A patient of leprosy has gone in 2 to 3 weeks. Skin symptoms gone in 2 months. Now, because the T half is 70 days, even 600 mg monthly dose works amazing. Don't use this in a patient who has hepatic or renal dysfunction or has erythema nodosum leprosum. Don't give it. Or even in a reaction called as reversal reaction, you should never give rifampin. It will be much more dangerous. It will actually release so many mycobacterial antigens because of killing of the bacteria, that these reactions will become exaggerated. So be very careful. Simple enough. Moving on to ofloxacin. Now we have covered this in ciprofloxacin chapter. You know the mechanism of action and all that thing. If you give only ofloxacin to a patient suffering from leprosy continuously for 22 days, 99.9% bacilli would be killed. This is not a part of the standard treatment protocol that we have. Okay, so it can be added as a component there. It will speed up the killing of the bacteria and clinical response, but it is not in the standard protocols. That's what I want you to understand. You can see, as a private practitioner, you can do whatever you want to do, and this is a good addition. Give it 22 days, done. The patient is 99.9% bacteria free. But these are like alternative regimens. Okay, in case rifampin cannot be used, then you can do this. Otherwise, ofloxacin and all, nobody uses. This is most potent fluoroquinolone against Mycobacterium leprae. Simple. Moving on to minocycline. Now these part, like ofloxacin onwards, are some MCQs. Okay, minocycline is highly lipophilic. Highly lipophilic, loves lipid, plain and simple. Okay, this medicine 100 mg per day will give you a peak blood level that is more than the minimum inhibitory concentration by 20 times, 10 to 20 times. So if I have to arrange the killing capacity of these medicines, then I would say rifampin would be preferred over minocycline over clarithromycin. The only serious complication that happens because of rifampin is basically vertigo. That's the only serious complication. Many doctors are trying some alternative anti-leprotic treatments. In them, minocycline has a role to play, not in the standard protocols. And lastly, we need to know a little bit about clarithromycin. This is the only macrolide antibiotic with significant activity against M. leprae. You give 500 mg daily for 8 weeks, 99.9% bacteria are killed. Now, at this point of time, you know all the medicines. Most importantly, you know what we call as the drugs that we have to use in MDT, multi-drug therapy, which is rifampin, dapsone and clofazimine. You know these, right? Now, let us classify our patients into two main categories. Is the patient paucibacillary or is the patient multibacillary leprosy? A person with paucibacillary leprosy has only 1 to 5 lesions on his skin. There are no peripheral nerve involvement, or maybe only one nerve is involved, and the skin smear at all the site is negative for bacilli. As compared to multibacillary, where there are 6 and above number of skin lesions, more than one nerve is definitely involved, and skin smears are positive. So this is how you will start. You will start a multibacillary leprosy treatment with the following medication. You will ask the patient to come to the clinic, and on the day he comes to the clinic, let's say he's coming on January 1st. Okay, so he came on January 1st. You give him in front of you rifampin and clofazimine. 600 mg of rifampin, 300 mg of clofazimine in front of you to eat. He eats that, then you give him a strip, 30 tablet strip of dapsone 100 mg and 30 tablet strip of clofazimine 50 mg. And you ask him to go back home and take 1 tablet dapsone, 1 tablet clofazimine every single day for the next 30 days and come back again at the end of 30 days. For sake of simplicity, I am writing Feb 1. Again, when he comes, you will give him rifampin and clofazimine in front of you and dapsone and clofazimine at home. Dose of clofazimine in front of you is 300 mg, at home is 50 mg. If you do this properly for 12 such cycles or 12 monthly pulses, the patient will be free of multibacillary leprosy. As a case of paucibacillary leprosy, you don't require that much treatment. So you give rifampin 600 mg once a month in front of you and dapsone 100 mg daily for home consumption, and you do 6 such rounds and the patient will be absolutely fine. You can take a screenshot of this video or this particular screen. This is an MDT for child. I've just given it because sometimes in postgraduate entrance exams they can ask you this. This is not important from your theory exam perspective. Even this is not important from your theory exam perspective. I am just giving you an overview of what you need to know extra over and above what is there in your textbook. Is that clear? So as far as I am concerned, your next action step should be to do the following questions. Save this. I will see you next video. Till then, take care, keep studying and keep rocking. Bye bye.